So after the wonderful oration by Dr. Jose sir, we will move on to the next session. That's on the brain matters, Resynapse, the neural network. So I would like to call upon Dr. Amarja Havaldar on the stage. She is the chief moderator for the session. And the chairpersons, Dr. T.S. Ravindra. He is the consultant physician at Mallige Hospital, Bangalore. Please come on the dais, sir, for the next session. Please chair the session. Dr. Swapna Kanode. She is the consultant physician and intensivist, Nagpur. Dr. Narendra Rungta, senior consultant, Rajasthan Hospital. Dr. Jojo K. John. He is the head of the department, Critical Care Medicine, Medical Trust Hospital, Kochi. Dr. Subhash Acharya, who is a consultant at Tribhuvan University, Kathmandu, and Dr. Shitida Kulkarni, she is the regional head medical services, Manipal Hospital. So I would request Dr. Amarja to take over the session.
So moving on, we'll start next session, that is Resynapse the neural network, brain matters. So we'll start with first talk. It's on hemodynamic optimization in non-traumatic brain injury. So I would like to call upon stage Dr. Arindam Kar. He is the additional director working at Sir H.N. Reliance Foundation Hospital, Mumbai. Over to you, sir.
Okay. Hi, good afternoon. So it's a long topic and 15 minutes. Okay, I thought it's 12 minutes and okay, 3 minutes I got extra. This is where I work. Mumbai, I shifted from Kolkata to Mumbai. A little recapitulation on the physiology. We know that there are special needs for the brain because 20% of our VO2 is required for the brain. As though it is only 2%, but almost 15 to 20% of the overall cardiac output is directed towards brain, and the blood flow rate is quite high, 55 per 100 gram of brain tissue. There are different circulations, the circle of Willis, which creates a safety net, and the blood vessels are surrounded by specialized barrier. We know that the blood-brain barrier. And quite a unique thing that the extraparenchymal pial vessels and the parenchymal pial vessels have a separate neuronal supply. And that means that the autonomic regulation of only larger arteries, but not the parenchymal arteries, which respond to the parenchymal arteries respond only to the local neuronal activity. So that's quite pretty unique on that part. And we know that there are certain determinants of the cerebral blood flow. So whether it is an autoregulation or a neural regulation, chemoregulation, and certain times the endothelial dependent regulation. And we know the formulas of cerebral perfusion pressure, and cerebral perfusion pressure divided by the vascular resistance gives you the cerebral blood flow. And this is what we call the autoregulation, the static and dynamic both, right? Over a certain range of the blood pressure changes, the cerebral blood flow, the autoregulation maintains a standard, a steady cerebral blood flow. So it could be static and this could be a dynamic itself. And also we know the Monro-Kelly doctrine that the brain is a fixed space, the volume is fixed space. So if there is something unwarranted, so you have to change either the blood flow, you have to drain the CSF, or you have to maintain an adequate venous drainage itself. So this is the overall volume of this. So what happens when for any reason, traumatic or non-traumatic, the ICP goes up, there is a decrement in the cerebral perfusion pressure which leads to ischemia. Ischemia leads to the impairment in the cerebral autoregulation, right? And it increases the cerebral blood volume, leads to cerebral edema, and the cycle repeats. So that goes into a vicious cycle, right? So this is what we see, the overall A, right? So blood pressure variability and overall A. So two compensatory mechanisms. One is the autoregulation, which tries to maintain the cerebral perfusion pressure. The other one is the oxygen extraction. The brain tries to get more and more oxygen, extract more and more oxygen. So whether this is in the penumbra region or a oligemic region, there what the maximum autoregulation and the extraction do happen, because in the infarct core or in the normal segment, the overall either one is already dead and the other one is already in the normal, and this is the normal cerebral autoregulation, and this is the dysregulation when what happens is with the increment or the decrement of the blood pressure, the brain no longer can autoregulate and maintain the cerebral blood flow itself, right? So we all know that this is the basics of it, and these are the certain modifiers of autoregulation, particularly the posture, the temperature, the pH, the oxygenation, carbon dioxide. So we all know that how it changes, and we can modify that. The clinical scenarios in non-traumatic, because we all know that traumatic brain injury, a lot of work has been done, but this is also important, maintenance of the hemodynamics to improve the eventual outcome in non-traumatic brain injury. The scenarios are acute ischemic stroke, hemorrhagic stroke, subarachnoid hemorrhage, and certain others, particularly the seizure disorders and the metabolic encephalopathy, particularly the fulminant hepatic failure, where the cause of death is the raised ICP itself, primary cause of death itself. So we all know that this is the general idea of managing a neuro patient. Both it starts from the pre-hospital scenario and goes up to the rehabilitation itself, right? And what we can do that at most of the times the primary injury cannot be prevented, but a good critical care and a neurocritical care can prevent the secondary and tertiary injury of the brain itself, right? And this is the optimization of all the support, but most importantly the hemodynamic support, where you have to optimize the blood pressure, fluid balance, which eventually can actually give a good outcome in the organ crosstalk. That means it can give you a better kidney, lung and heart function, and eventually it minimizes the secondary injury and improve the overall patient outcome. So let's see, we all know that time is brain, right? And what happens in ischemic stroke? We have an ischemic core and we know that we have a penumbra, and the most of the time the hemodynamic optimization is to improve the circulation in the penumbra, because this part is still salvageable. The infarct core is gone, but the penumbra is still salvageable, and the maximum work whatever we do is to salvage the penumbra itself. So that's the primary aim, right? And the two therapies we all know of which constitutes the reperfusion is thrombolysis and mechanical thrombectomy, and we all are doing it, and we know the timing, because all these studies, Mr. Clean, Escape, Extend, Swift Prime and everything, they have changed our attitude towards the treatment of acute stroke, particularly endovascular therapies itself, right? So Dawn and Diffuse and all this trial, and these are the mechanical endovascular thrombectomy, because not only we are doing thrombolysis, but we are combining thrombolysis both with our standard thrombolysis or intraarterial partial thrombolysis along with mechanical thrombectomy itself. So this is in summary that what we do, and along with that we have to have a perfect hemodynamics itself. So hemorrhagic transformation with higher peak systolic blood values or hemodynamic variability in the first 24 hours of EVT has to be prevented itself. And these are all the trials that has been done: Escape, Revascat, Swift Prime, Extend, Dawn and Diffuse. And everywhere it is saying that before reperfusion, accept a little higher blood flow, but once you have done a reperfusion, the blood pressure has to come down, otherwise there could be a lot of hemorrhagic transformation or the complications itself, right? So this is the blood pressure management of successful thrombectomy, right? You can see the blood pressure target should be in and around 140, a little below the 140. So all these given the newer trials, and see what happens when you do a perfusion. Sorry. So this is the penumbra and all others. and then you do a reperfusion therapy, you have a beneficial outcome. But there could be pitfalls because there could be no recanalization. At times there would be recanalization but no perfusion, or other at times there could be vascular complications. And a lot depends on the hemodynamic optimization of this. Either you have to have a good flow, but you have to also control the blood pressure in such a way that it doesn't bleed in the patient itself, right? So otherwise you will have a hemorrhagic transformation itself, or a hyper reperfusion syndrome, just like what we have a reperfusion injury in the brain also, that can happen. So the BP after acute ischemic peri-procedural management of blood pressure, which is primarily our duty because the interventional radiologist has already done their job, right? We have to keep a BP. The target is primarily less than 180 and the diastolic in and around 105 to 110. And do not hesitate to have an invasive blood pressure management, but albeit you have to be careful on because many of the times the patient does have thrombolytic therapy, so there should not be any complication of that. And the agents that we normally use, there is no recommendation clear on that, but the standard agents that we use are labetalol and nicardipine, IV nicardipine, which is now available in the country. So there are other complicating factors depending on the reperfusion, infarct size and others, but the overall, after multiple studies and observations, we come to know that now you have to maintain a BP below a fixed predetermined value as recommended by the current guidelines, and stratifying BP thresholds based on the reperfusion status. That is important, and this is very important slide. So we have now the MTC score, that is the modified thrombolysis and cerebral infarction score, according to the perfusion, just like the TIMI in the MI system, right? So this is the different where in the grade 0 you have no perfusion, in grade 2 you have partial perfusion, and in grade 3 you have complete perfusion. And you also A and B in the grade 2, where it is depending upon that whether you have a more than 50% or less than 50% perfusion itself, right? And this slide, if you see that if you have an optimal BP in the first 24 hours after therapy, if you have a successful recanalization and more than 2B, if you have, then you maintain your blood pressure, systolic blood pressure, aggressively less than 160. Right, because that otherwise the chances, one is there is a good perfusion as well as the chances of hemorrhagic transformation is reduced. And wherein in unsuccessful recanalization, right, just to maintain a perfusion in the penumbra zone, because the recanalization has not happened, permissive hypertension is accepted. So do not aggressively reduce the blood pressure. I will come to that point where inducing agents using vasopressors, what is the take on that, the vasopressors? To summarize, no fixed BP is perfect. Better to check and confirm TC post EVT to decide on the optimal target itself. Close monitoring for blood pressure, if required invasive blood pressure monitoring, and strict neuroprotective measures, standard therapy for neurocritical care. And more than single value, the variability, the blood pressure variability kills more. Right, and obviously in any case, in any critical care topic, we need more RCTs to confuse ourselves. So in hemorrhagic stroke, we know that no significant ischemic penumbra is there. There are two trials which has given maximum insights on it. One is the ATTACH and the other is INTERACT. They have shown that the rapid reduction of SBP to less than 140 can be done. It is still safe. And in INTERACT 2, the follow-up of the INTERACT 1, there is no increase in death or serious adverse event from early intensive BP lowering. For ICG patient, this is the AH and ASA recommendation 2021, that you can, if the blood pressure SBP is between 150 and 220 and there are no other contraindications on acute BP treatment, you can reduce to the blood pressure SBP to 140. And if there are the patients has come with a SBP of more than 220, you can, if there are no contraindications, clear contraindications, you should go for a aggressive reduction of the blood pressure with continuous monitoring. So this is a very clear indication on that. In regarding the subarachnoid hemorrhage, We all know that there are a lot of variability in the blood pressure itself, and before and after of the coiling and clipping, you have to treat the BP separately, differentially. So it is reasonable to treat severe hypertension on presentation. There is insufficient evidence to recommend a particular BP target, but profound reduction of BP should be avoided. And these are the things, including certain reversal of the anticoagulation is also important. And gradual reduction of the BP is required if the patient is severely hypertensive, more than 180. Strictly avoid hypotension because of the thrombosis that can happen, and early goal-directed therapy. We all know the traditional Triple H therapy is controversial now, and we are not sure about the benefits of volume expansion, but we are sure about the bad effects of the volume expansion itself. And there are no gold standards on the different modes of circulatory volume measures and the impact of overall outcome. And this is also that the TCD has proved a very good non-invasive safe bedside neuromonitoring, but in advanced centers we are also doing cerebral microdialysis and brain oxygenation monitoring, as well as the lactate pyruvate ratios, which have all come into the recommendation itself. And we also know that we have to be very aggressive in treatment when we have already done the interventions, and how to prevent the secondary complication itself. Okay, I'll take 1 minute more. Yeah, last couple of slides where I want to show the brain-heart crosstalk. So this is what the brain affecting the heart itself, and all the stroke, be it ischemic or hemorrhagic, has got a repercussion of the cardiovascular system, mostly through the gut microbiota, with neurohumoral system, with the inflammatory or the cytokine storm, as well as activation of the hypothalamic pituitary axis, and that affects eventually the blood-brain barrier, as well as the variability in the blood pressure can also not only have poor neurological outcome, but it has also got a direct impact on the cardiovascular system. So there are a lot of work has been doing where oral anticoagulation, very aggressive management of the arrhythmias, gene therapy, and particularly beta blockers are being used to reduce the impact of the neurological on the heart itself. So I'm not going into the summary. Mostly this is the acute hemorrhagic stroke in and around 140. In the ischemic stroke, if you are not intervening, you have to reduce the blood pressure. If you are pre and post thrombolysis, the targets are around 185 to 180, and thrombectomy around 180 to 105 itself. And this is the complete list of where you have very clear targets of the blood pressure itself. I want to show this guy, Niels Leysen, who came up with the concept of cerebral dysregulation. Until the time we have the answers, we have now new complexities that coming up. Anyone who is this guy? Chairpersons and others. I always put a quiz at the end. I'm a quizzer. So from the audience or the chairperson. This is Sergio Canavaro, who is contemplating a head transplant itself with a very, very aggressive hemodynamic management of the neurological patients itself. So thank you, and more complexities will come when all these things, and we have the advancements, and also the AI is coming into the neurological monitoring, but that would be a completely separate topic. So time is brain. And the last slide, always, these are the guys, 9 people who are fasting for last 14 days now. Out of that, 6 people are already being hospitalized. So please give your support and solidarity towards the young doctors who are fighting for a cause for us. Thank you.
Thank you, Dr. Anandam, for covering this rather vast topic in a very, very concise and beautiful way. Thank you so much. So since we don't have the question answer session because of want of time, I would like to invite our next speaker, Dr. Rajesh Pandey, who's Principal Director and HOD at Center of Critical Care Super Speciality Hospital, BLK Super Speciality Hospital, Delhi. And he will be talking to us about another unusual topic, autoimmune encephalitis, diagnostic and therapeutic dilemmas. Over to you, sir.
Thank you, Chairperson, for the kind introduction. At the outset, I'm grateful to my friends Pradeep and Ajit and the organizers of JIGS for having me here. Two disclaimers before I start my talk. One, I'm not a neurologist. It's a difficult topic. And number two, with second disclaimer, with no malice towards my neurology colleagues, it's a difficult topic even for them, as you will see. So normally when we identify encephalitis, we mostly look at its correlation with infectious origin. And the incidence is quite high, but mostly we, if you look at the different countries, specifically, for example, UK, it is HSV or varicella zoster. So viral infections and encephalitis are associated. Why I am raising this issue? Because infectious causes are the most recognizable causes of encephalitis. So as a result, the existing diagnostic criteria, consensus guidelines are also biased more towards the infections. And it's only the last decade or so where our information and knowledge about autoimmune encephalitis have increased significantly, and we have been able to identify the autoantibodies, and our understanding is better. And, so autoimmune encephalitis can develop with core symptoms which resemble the infectious encephalitis, and also with neurological, psychiatric, behavioral manifestations. There may not be any fever or pleocytosis, so that complicates the whole thing. It's generally associated with autoantibodies, could be against the neuronal cell surface or synaptic proteins. So these are some of the antibodies that have been identified. So you can see against intracellular antigens, against synaptic receptors, where anti-NMDA receptor antibody is the most common that we see, and other, for example, the LGI1, limbic encephalitis associated. So these are some of the autoantibodies that have been identified. The typical radiology or the brain imaging doesn't really help, as it helps in maybe meningoencephalitis, so because the patterns are quite variable. So the first question that comes to mind is, why does it occur? Well, basically there is a derangement or shift in the immune system, immune response, and it's not very clear as to what is driving this change in the immune response. Brain cells are being identified as pathogens, and autoantibodies are being formed against them, the brain cells or the brain matter. And several things have been found to be associated with this. For example, in cancers, the paraneoplastic conditions, immune cells, immune system tries to suppress the cancer, but that also harms the brain. HSV encephalitis, it's found that up to 25% of the patients can develop autoantibodies and later on have autoimmune encephalitis. So cancers and infections, fortunately we can identify if they are responsible, but if that is not the case, then it is very, very difficult to identify the autoimmune encephalitis. The puzzle remains as to why the immune system is shifting to identify brain tissue as pathogen, and also why different type of autoantibodies are associated with predilection for different parts of the brain. So as much as 20 to 30% of encephalitis can be because of autoimmune encephalitis, autoimmune causes, and largely the autoantibodies will be formed rapidly over a few days to say weeks, but sometimes chronic association, insidious onset has also been observed, particularly in LGI1 antibody or Caspar-2 antibody. Presentation when it is insidious may look more like neurodegenerative rather than florid encephalitis, and that leads to delay in the diagnosis as well as delay in the immunotherapy. So even if it is diagnosed early, acute onset, if you are waiting for to identify the differential, rule out the differentials, and to look at the specific autoantibody, then the treatment may be delayed. So much so, like I said, the neurologists are confused. This was a important study which looked at autoimmune encephalitis misdiagnosis. This was by Mayo Clinic, where they looked at all the major academic centers. They found 27% of the cases were misdiagnosed, largely because of overinterpretation of non-specific autoantibodies or misinterpretation of the symptoms. And various things ranging from functional neurological disorders to cerebral neoplasm were misidentified, misdiagnosed as autoimmune encephalitis. So it remains a problem as far as diagnosis is concerned. The earlier belief that it is rare is not true. It is not rare. California Encephalitis Project identified an NMDA receptor antibody encephalitis as to be as common as any infectious cause in that region. So this is as common as viral causes. Now there have been attempts to classify this, and people have tried to classify as per the anatomy or the serology or the etiological classification. If you look at the etiological classification, idiopathic, paraneoplastic, post-infectious, iatrogenic, that means the subject is still evolving and it is still very, very complicated. So how does the patient get affected? It could affect the cognition part, thinking part. It could lead to personality changes, behavior changes, development of seizures when there was no previous seizure disorder, or sometimes induce coma. The diagnosis could be based on clinical features, maybe sometimes brain MRI is helping, or identification of specific autoantibodies in CSF or blood examination. So some association has been identified with specific autoantibodies. For example, the psychiatric behavioral problems like aggression, irritability, mood lability, etc., more with LG1 and NMDAR autoantibodies. Cognition, etc., where disorientation, confusion, amnesia, more with LG1 and NMDAR again. Seizures with the LGI1 autoantibody, where it is largely focal, rarely it is GTCS. So that way the association with autoantibodies have also been identified. So this slide tells you the association. My focus is on first two NMDAR autoantibodies and the LGI1 antibodies because they are more common. NMDAR affects the young females, acute onset, mixed psychopathology, complex movement disorders with hyperkinetic catatonic fluctuations, dysautonomia in females often associated with ovarian teratoma. So that screening is also important here. LGI1, elderly, mostly males, insidious onset, frequent focal seizures, including the fatiobrachial dysautonomic seizures, amnesia, serum hyponatremia. And maybe sometimes you can see this would be the limbic encephalitis, but in all others it is non-specific. So possibly these are the situations where the radiologist would not release the report immediately, would like to discuss with the neurology and then come up with something, some working diagnosis, radiological diagnosis. You can see it here also. So here it is a classical MRI of limbic encephalitis, where you can see the bilateral medial temporal lobes are affected. But in all others, like this is associated with a glioma, it may be difficult. So I think it is difficult for the radiologist to interpret as well as for the neurologist. So it needs a discussion between the two to really come up with a working diagnosis. So what has been suggested is confirm local or brain pathology suggestive of autoimmune encephalitis. You can do brain MRI with or without contrast. EEG if MRI is negative, or if patient is having seizures, or if there is encephalopathy. You can also do brain PET if MRI is negative, just to rule out anything else or any association with malignancy. Confirm inflammatory etiology and rule out competing possibilities. So you can look at the CSF neuronal autoantibodies or blood serum neuronal antibodies. Brain biopsy is also recommended if things are still uncertain, and you can screen for associated neoplasm as well. So all these are the differential diagnoses that you can see. You know, right from infectious encephalitis to Hashimoto's encephalopathy, one has to see. Now the dilemma, as I've been saying, the antibodies, it is believed now when a working model is to be given, the group felt that antibodies should not be part of early diagnostic criteria because it is not readily accessible and the result takes time, report takes time. And also the fact that absence of autoantibodies does not exclude that the disorder is immune mediated, and sometimes you know, people are using the response to immune therapy as a diagnostic criteria. That is not recommended to be used. And in some patients, autoimmune encephalitis, because they believe might respond to immunotherapy, where you know, prolonged intensive therapy may be required, Or some patients may respond to immunotherapy where it is not autoimmune encephalitis like primary CNS lymphoma. So the diagnostic criteria that have been suggested, clinical one, subacute onset, that is rapid progression of less than 3 months of working memory deficit, altered mental status or psychiatric symptoms, at least one of the following new focal CNS findings: seizures unexplainable, CSF pleocytosis, MRI suggestive of encephalitis, and other alternative causes have been excluded. Similarly, when you look at the limbic encephalitis, they say all 4 of the criteria have to be met, where in addition they are looking at the bilateral brain abnormalities affecting the medial temporal lobes, and then CSF pleocytosis or EEG showing epileptiform discharges, and other causes are excluded. NMDA receptor encephalitis, again they have given the diagnostic criteria: probable encephalitis, rapid onset, psychiatric problems, speech dysfunction, seizures, movement disorder, decreased level of consciousness. So these could be there, and abnormal EEG or abnormal CSF, and other disorders have been excluded. When you can identify the autoantibody, then you can, along with these symptoms, then you can call it definitive NMDA receptor encephalitis. So these are the criteria for probable autoimmune encephalitis. In the interest of time, I'll skip this. So the treatment largely remains supportive. Supportive means you look at the treating all these issues ranging from psychological seizures, etc. And please see, the first treatment is acute immunological therapy in all of these. That means early acute immunological therapy would even relieve these symptoms. Specific are first-line therapy in acute stage are steroids, high-dose steroids, IVIG, and plasma exchange. Second line, if the first line fails, some say that to prevent recurrence, the second line is important: mycophenolate, azathioprine, rituximab, cyclophosphamide. Third line would be immunosuppressive therapy, toci and bortezomib. Outcome would depend on removal of autoantibodies that may relieve acute symptoms. Status epilepticus needs to be controlled. There could be bloodstream infections, and there could be later on cognitive problems of physical disability. So these are the suggestions. Now steroids, you have to use methylprednisolone IV in 1 gram daily for 3 to 5 doses, IVIG 2 gram per kg over 3 to 5 doses, and 3 to 5 sessions of plasmapheresis. And then second line therapy, like I said, mycophenolate, azathioprine can be used, rituximab, cyclophosphamide, and third line. So this is an algorithm that has been given, which basically if you have a suspicion of autoencephalitis, look at the presence of tumor. If the tumor is present, then you need to treat the tumor. Or if you find that you have started the IV methylprednisolone, but there is no improvement, then you look at the classical paraneoplastic autoantibody. If that is there, you put them on cyclophosphamide. If you find the picture is suggestive of the surface antibodies, and then the IV methylprednisolone can be followed by short or long-term oral prednisolone therapy and gradual taper. On the other hand, if you find the tumor is not associated with the autoimmune encephalitis, if it is mild to moderate, then you can start with IV methylprednisolone. If it is contraindicated or there is high bleeding, then you can use the IVIG, or you can use Plex in case there is a problem with thrombosis. If it is severe, then you can consider the combination therapy. All of them you can consider. And subsequently, if there is no improvement, you move on to the second line therapy. So this is again the same thing. You can see it here clearly. So it's been identified that treatment modalities differ. So even among the neurologists, there is no universal acceptance of one therapy. So this shows you that in acute, people have used for unspecified, methylprednisolone was the most commonly used. Otherwise, the methylprednisolone and Plex were commonly used for NMDR antibody encephalitis. For IgI, methylprednisolone and where you suspected paraneoplastic, all of them were used. For second line therapy, you can see most often if it was refracted to the combined combined therapy. My final remarks, this is my final slide. Evaluate the likelihood of autoimmune encephalitis. You can do MRI, EEG to look for focal or multifocal abnormalities. Look for CSF and blood autoimmune antibodies. Consider the FDG PET-CT if there is high suspicion of autoimmune encephalitis. Other studies are uninformative. Perform cancer screening. Start high-dose IV methylprednisolone. If there is no improvement, IVIG in those with agitation, bleeding disorders, Plex in those with high thromboembolism risk and severe hyponatremia. Consider combination therapy from beginning for severe presentation. If no improvement in 2 to 4 weeks after combined therapy, you can move on to second line therapy. If no improvement, then third line. Start bridging therapy. Gradual oral prednisolone taper. Avoid steroid taper or implement a short taper in patients with poor response to immunosuppressive therapy. Some people say that second line therapy must be instituted to reduce the recurrence. Thank you very much for your attention.
Thank you, Dr. Rajesh Pandey, for giving a short overview of such a complex topic. Because of time, we will be taking the question and answer during breaks. Now we'd like to call upon our next speaker. Our next speaker is Dr. Akhilesh Tandekar. He is the head consultant critical care at Wockhardt Hospitals, Mumbai. And he is talking about balancing act of sedation in acute brain injury. To you, Dr. Tandekar.
Thank you, respected chairpersons. Good evening, everyone, and thank you, Jigs. Today I'm going to discuss about the sedation in acute brain injury, though it is one of the gray areas in management of the traumatic brain injuries, and it is little complex as well. The tweaking of sedation is very complex. Too much sedation and too much lower sedation is also harmful. So how do we balance the sedation? That is what I'm going to focus on this presentation today. So as we know, in general intensive care, the focus is on relieving anxiety, pain, and agitation when somebody is sedated. And if the patient is on mechanical ventilator, the emphasis is to maintain the patient ventilator dysynchrony. But this is exactly, a little different. We cannot say different, but it is an additional focus that we need to have in patients with the acute brain injury, where we also have to focus on managing oxygen demands of the brain and maintaining intracranial pressure and seizure control and temperature management. These are three important aspects that we additionally have to look at it as against the general intensive care patients. And ultimately what we emphasize is, and what we really aim is to give safer physiological situation to the patient. And it should also be able to provide some sort of analgesia. It's not just the sedation, but the analgesia also needs to be given together. We call it as analgosedation. And then the care delivery should be efficiently delivered. If the patient stays calm, quiet, probably the delivery by the healthcare professionals is quite efficient. And the patient should not also be aware. The anxiolysis is also very important. So these are the important aspects that, when we sedate the patient, we have to look at it. And ultimately, the brain protection. If the brain is not protected, whatever kind of sedation you give, higher or lower, it has no importance at all. So while we give sedation, how does the sedation helps you? Managing a patient with a traumatic brain injury is like when we give sedation in optimum doses, it suppresses the cough, the intrathoracic pressure is controlled. Generally, the intrathoracic pressure gets transmitted to the brain and it increases intracranial pressure. So that way, the intracranial pressure is indirectly controlled. The patient remains calm, quiet, and he doesn't have pain, and he doesn't have agitation. The hemodynamic changes or alteration that happen, change in heart rate or change in blood pressure, these fluctuations are controlled at large. And sedation is also helpful in taking care of the patient's oxygen delivery and demand. And also, it will also help us to maintain the oxygen status and carbon dioxide balance. Okay, because excess of carbon dioxide is also harmful to the brain, and that is very important. We need to look at it. And then it will facilitate the patient being on ventilator if the patient is ventilated with severe acute brain injury. And ultimately, the goal of sedation is to reduce the cerebral blood volume and ultimately reduce cerebral intracranial blood pressure. So now look at the intracerebral or intracranial compliance. So intracranial compliance is nothing but maintaining the autoregulation, and the autoregulation is largely dependent upon how much pressure is inside the brain, and that pressure inside the brain has a logarithmic relationship with the intracranial volume. And the emphasis is to reduce the intracranial volume, which is achieved with sedation. So when we give sedation, the blood volume in the intracranial cavity, is reduced, and overall it reduces the entire volume inside the brain, and indirectly the pressure is controlled. So there are competing goals of sedation in intensive care with acute brain injury. What do? Do we deeply sedate the patient, or we keep the patient with the lighter sedation? So deeper sedation has its distinct advantages, like controlling intracranial pressure and brain tissue oxygen demand is also controlled. When the patient is shivering or patient has systemic elevated oxygen requirements, that is also controlled, and the patient ventilator dysynchrony is controlled, and then it can prevent the seizures. That is achieved with a deeper sedation. Probably the lighter sedations may not be able to help us controlling all these parameters, but lighter sedation can help us to assess the patient more frequently, because sometimes the clinical parameters get missed with the deeper sedation. And it will also keep the hemodynamics also at check. The hypotension and prolonged duration of sedation leads to delirium. That delirium also can be controlled, and the weaning, mobilization, rehabilitation also can be facilitated if the patient is in the lighter sedation. How lighter sedation? We need to have a good balance. It's not too light or too deep, but a perfect balance of sedation can definitely prevent the harm, the physiological alterations, and the oxygen requirement or the intracranial pressure. All that can be controlled with the perfect balance. And how do we assess whether that balance is well maintained or not? It's all, clinically, from good old days, we have seen that clinical parameters have been challenged, but the clinical parameters have been really of great help. But most of the times, the efficacy of the clinical parameters is obscured. For example, if you see Richmond agitation score, this has several parameters, but there is no balance. We are just assessing the patient's external appearance, whether he is agitated or restless, or he is drowsy or unconscious, and these parameters are not balanced. If you see the parameters above 0 and below 0, they are different. Okay, so it is very difficult, and you are not exactly assessing what's going on inside the brain. So that's why you need monitoring devices. Okay, EEG, intracranial pressure monitoring, and then brain tissue oxygen saturation monitoring, and even transcranial Dopplers have come to our help to assess the velocity of the flows and the blood flows. We can have a real-time assessment of the blood volume with these different tools, and indirectly we can control the intracranial pressure. How about the frequent awakening of the patients? Your neurologist or neurosurgeon will quite often ask you to keep the patient awake, if he has acute brain injury. But how these neurological wake-up tests really be helpful? It has a lot of disadvantages, because when the patient is sedated and you suddenly stop sedation and try to awaken the patient, it will lead to a lot of hemodynamic change. Patient's blood pressure will increase, heart rate will increase, there will be sudden rise in intracranial pressure, and then the oxygen delivery and consumption will also get alterated. There will be differential results with the brain tissue oxygen saturation, and and even microdialysis studies also have shown that the perfusion also gets altered. So neurological wake-up test is really challenging. When to do that, we'll have to really see. So many studies have shown that only in 1/3 of the patients with the acute brain injury you can really do neurological wake-up test. And in those patients, of 1/3 patients, when you do neurological wake-up test, you cannot do it completely, or you have contraindications due to raised ICP or agitation, or patient is in respiratory distress. And most of the times, you see 50% of the times you will see worsening of the condition if you are not assess the patient well, and you are not assess and you are not given a neurological wake-up test in time, there will be a worsening. There are a lot of unanswered questions with neurological wake-up test. Does it justify the risk that is associated? How much secondary brain injury it causes, and what are the long-term impact on the outcomes when the patient undergoes a neurological wake-up test? And does it really lead to a important clinical deterioration? These factors are unanswered. So that's why it is necessary that wake-up test is only done when the intracranial pressure is under control, patient is stable, is not hypoxemic, and he is not having active seizures. So probably we can do, but otherwise neurological wake-up test is contraindicated in early acute brain injury. Hypotension is disastrous. We have seen the autoregulation. Brain has a cerebral autoregulation which maintains the harmony inside, and if the autoregulation is compromised, there will be passive pressure collapse, there will be vasodilatation, and that will lead to cerebral ischemia. So the target should be to maintain cerebral autoregulation by keeping a good blood pressure, mean arterial pressure of 90 to 110. But it should be individualized. It cannot be just 90 to 110, but it should be individualized. How does this hypotension affects the brain? Hypotension will lead to precipitous decrease in the blood pressure, which will compromise the intracranial pressure and will lead to cerebral ischemia. So how do we give these sedative agents, and what agents are preferred in patients with acute brain injury? There are so many studies, 13 randomized controlled trials, and 6 studies have evaluated the efficacy of sedation in acute brain injury and even in traumatic brain injury. So these studies are small, with very small sample size, and these studies also have a lot of bias. So the studies have not been able to really evaluate what sort of sedation agent is better or not. But we have these number of sedative agents, right from propofol to midazolam, dexmedetomidine to ketamine, and propofol has been found to be quite effective in reducing intracranial pressure, but it is associated with hypotensive episodes. And propofol infusion syndrome is one of the dreaded complications with long-term sedation infusion. Midazolam, though it is a short-acting agent, but with continuous infusion, it becomes long-acting, and it causes a lot of delirium post-recovery. And then dexmedetomidine, though it reduces delirium, but the intracranial pressure control is still debatable. It is associated with bradycardia, hypotension, and it can be used only for a short-term infusion. Ketamine, though it was blamed to increase intracranial pressure, but the rise in intracranial pressure is not that significant to compromise the perfusion of the brain. So ketamine, the larger role is in seizure activity, but it can also be a good adjunct along with the other sedative agents to control the intracranial pressure. And the barbiturates, ketamine, and even isoflurane, these are some of the agents which can also be very useful in controlling the intracranial pressure. So these are the comparative, studies with propofol, midazolam, ketamine, and sufentanil, and propofol and morphine. So there is no difference in control of intracranial pressure, cerebral perfusion pressure, and mean arterial pressure, except in the study with the propofol and morphine, where the reduction in ICP is quite significant, but the cerebral perfusion pressure change is very, very less, and the vasopressor requirement is high with propofol. And when we compare propofol, fentanyl, and midazolam, fentanyl studies, the midazolam fentanyl combination is associated with increased length of stay, and the awakening time is very long, 17 hours compared to propofol remifentanil, where the awakening time is just 2.5 hours. And if we see, these studies have really been helpful to reduce the length of stay, mechanical ventilator days, and overall the cost associated with the treatment can also be reduced. This dexmedetomidine and propofol study, though it has been evaluated extensively, but it did not find any superiority. And algo sedation is the way forward, and protocolized sedation approach should be advocated, and we should tailor the treatment, sedation, and control of intracranial pressure. So it should be an individualized approach. No patient is, all patients are not similar. We have to individualize and consider the physiology and pathophysiology that is going on in patients with acute brain injury. And I would like to summarize, like, neuroprotection is the hallmark of management of patient, with acute brain injury when we advocate sedation. The importance is on therapeutic goals, and we monitor the side effects, and we should be able to titrate the sedative agents according to the need of the patient. With this, I will like to conclude this session. Thank you very much.
Thank you, Dr. Raklesh, for clearly highlighting the challenges of the balancing act and showing us the way forward. Now we have an interesting debate. The statement to be debated is that targeted temperature management after cardiac arrest is beneficial. Can I have a show of hands? How many in the audience believe or agree with the statement? A show of hands, who believes in it? All right, Dr. Asif, you have to struggle, I believe. So to argue for the statement, we have Dr. Asif Ahmad. He is a HOD of critical care in Tata Main Hospital, Jamshedpur. Over to you, Dr. Asif.
Thank you very much, sir. And good afternoon, ladies and gentlemen. So there is an age-old rule which says that when you're in Rome, do as the Romans say. The second rule is that when in Rome, always say what the Romans say. But the pro-con rule always says that even when you're in Rome, if you're not convinced, speak against what Romans say. And whatever, just fight for what is right and evident. And with this background, we just go ahead with understanding as to how targeted temperature management after cardiac arrest is beneficial. As we all know, cardiac arrest is quite dreadful. The American Heart Association published in 2022 and said that almost 1,000 people a day are affected, and it includes people of all age groups. The European Council also talked about the severity, where they said that out of hospital cardiac arrest, the incidence was almost 67 to 170 per lakh patient, where the survival was just around 0 to 18%, and the in-hospital cardiac arrest was 1.5 to 2.8 per 1,000 admitted patients, and the survival at 30 days or hospital discharge was just around 15 to 34%, but still better than the earlier times. Now, the Indian registry, we are fortunate enough to have this data, and this talked about a survival rate which is just around 6.6 to 8.2%. The severity continues, and what next? Once we revive these patients, I know a lot of emphasis has been on training, on teaching CPR and ACLS, but once you revive these patients, what comes next is basically that even after surviving from the cardiac arrest, most of these die due to post-cardiac arrest syndrome. And the reason for that is the ischemic reperfusion injury affecting the whole body. The problems are the post-cardiac arrest brain injury, you have the myocardial dysfunction, you have the ischemia reperfusion happening, along with the precipitating pathology that's always there. Then came the role of the post-cardiac arrest care, and as you can see, the neurological care, the hemodynamic support, the coronary reperfusion, all of it are an important component of the whole entity called the post-cardiac arrest care. And this was included in the chain of survivals, where post-cardiac arrest care had quite a significant contribution to play, and it has been a boon for all of us. Now, there are a lot of problems which are happening because of the ischemic reperfusion injury. As you can see, the inflammation, the cytotoxicity, apoptosis, free radical injury, blood-brain barrier disruption, and the cerebral edema which happens. And here comes the role of hypothermia, because it reduces the cerebral metabolism, it preserves the ADP, helps in maintaining a pH, edema, and also promotes neurogenesis. The same aspect is applied to the cardiac protection also, where it talks about protection in terms of decreasing the inflammatory cell infiltration, apoptosis, and decreased expression of the pro-inflammatory cytokines. The concern is that if you don't handle this, then the patient goes down further, as we have seen earlier, and there it is where the target temperature control or the management comes into play, and this has its own importance. Now, there were landmark trials. It was just not out of that was not just out of any random trial or a random note that this whole systemology came into existence. So this was the first trial, the HACA trial in 2002, which showed that while having hypothermia induced, the patients did have a better neurological outcome and reduced mortality. This formed the genesis of the trial for putting up the targeted temperature management as one of the strategies. And this was immediately followed by the Bernard study in 2002, which again said that there's a strong evidence that mild therapeutic hypothermia between 32 to 34 after out-of-hospital cardiac arrest improves survival and reduces neurological injury. Over the period, it was continued, and then the Hyperion trial came in 2019. almost 15 to 17 years later. And this also said that the use of moderate hypothermia improved neurological outcome at 90 days. So people have been studying and taking a lot of importance of the fact. Another systemic review showed that it did improve survival and neurological outcome, and that was very soon, sometime around 2020-21. Now, the most recent was the Cochrane trial, which said that there was a reported beneficial effect of therapeutic hypothermia at 32 to 34 degree on neurological outcome, but it did not improve survival. And the guidelines over the years, as you can see, 2005 AHA guidelines, 2010 AHA guidelines, all of them started with 32 to 34, and they continued for out-of-hospital as well as in-hospital cardiac arrest. It was again given the terminology of a targeted temperature control in 2015, and they emphasized that, continuing it for the next 5 years as far as 2020. And the AHA guidelines of 2020 put it as a class 1 recommendation and to be followed for all patients who have a out-of-hospital or in-house cardiac arrest, and these need to be followed up if they are not improving. Even the International Liaison Committee on Resuscitation, ELCOR, also reaffirmed the same very fact, and 2003, 2010, 2015, and 2020, as you can see, all of it talked about the same interpretation of the beneficial effect, and then advocating the same of a 32 to 34 degree, which was initially there to 34, but then they found that it's beneficial and can be if we extend it to 36 degree also. So that was extended on from 32 to 36 degree also. And then the European Resuscitation Councils. I have named all the three because these are the important bodies which actually advocate, and they give us the way forward for all these situations. It again talked about maintaining the therapeutic temperature at 32 to 34 degree. And again, they also nomenclatured it as a target temperature control with 32 to 36 degree in 2015. And then it continued to 2021 when they said it should be continued at 32 to 36 degrees for the initial 24 hours, and also introduced it for pediatric patients. And 2 decades have really passed by, and the evidence is that all the people have benefited across the world because they have had the improved outcome in terms of the cardiac arrest resuscitation that's coming through. But then came the challenges, the new challenges. The TTM trial in 2013 showed that it does not improve any outcome when comparing 33 degree to 36 degree. And the most recent TTM2 trial, it said that induced hypothermia did not lead to improved mortality. And then there was a capital chill randomized trial also, which compared 31 degree versus 34 degree group, and they did not find any difference in the mortality and neurological outcome also. So based on these 2 studies, the new recommendations came. And the ESICM guidelines of 2022 said that there should be a continuous monitoring of temperature, and the focus now was on active prevention of fever rather than maintaining that hypothermia or the 32 to 36 degree centigrade temperature. And that followed with the ELCOR summary statement also, which said that it should be focused on actively preventing fever by target temperature of less than 37.5 degrees centigrade. And this was a weak recommendation with a low certainty of evidence. And the focus here again had gone up to fever rather than maintaining the temperature of 32 to 36 degrees. Now there were a lot of drawbacks. We need to also understand with the TTM2 trial, which is the genesis, there was a lot of negative prognostication in this set of patients with the withdrawal of life happening, leading on to higher mortality. There were 88% patients who received propofol, and there once this was used, what was the role on cerebral protection that was challenged. A lot of patients suffered in this category with post-arrest fever that is at itself quite detrimental for the outcome of these patients. And whether these results could be actually applied to patients across all groups, that was the question asked. And what about the in-house hospital arrest? That was something which people did not have an answer to. And even the study sample, some of the patients were added who were having a better arrest outcome. And so what was the situation for patients mostly who have out of hospital or who have a long duration cardiac arrest and where it is unwitnessed? Even the main problem that was highlighted was the inappropriate application of hypothermia, which was quite delayed, and it was not really applied aggressively in these set of patients as compared to the previous trials, which are quite positive. Now the trial that was another in addition to the TTM2, that was a capital chill randomized trial, this trial itself mentioned that it was underpowered. So we understand what is the evidence available. And then came the reviews. The resuscitation review said that the wide 95% confidence interval that was found itself tells that there's a lot of potential benefit which is not mentioned clearly, and people need to still look forward to the targeted temperature control. Now the studies which were done recently, if it was to be one of the landmark trials of 2022, they still did not include the in-house hospital cardiac arrest patients. Then if it's so, why the information was still incomplete? And the recommendations which we just saw, the recent ones coming in 2022 and 23, all of them were weak recommendations with a low certainty of evidence, but they were incorporated as taken as the rule of the land and to follow the same. Now, the ESICM also did not specifically say that you do not maintain hypothermia. They said there is not enough or insufficient evidence is present to recommend for or against the temperature control target that is 32 to 36 degree. Nobody negated it, but still they did say that they could be more beneficial if we come down with the fever. But no, I think that has been something which has still been challenged, is being challenged. And the DEEP trial showed further that the conclusions coming out from the TTM2 trial were not very significant, and patients, when compared later with other trials and registries, showed that they had a better outcome as compared to the mortality which was seen with normothermia or preventing fever in those set of patients. A new perspective said that the interest there has been in hypothermia and target temperature control has saved many lives over 2 decades, and we should not act prematurely on early promising findings till more evidence is available. And the most important reviews came which said that we should be interpreting the TTM2 trials with a lot of caution. I'll just take a minute, sir, with your permission. Yeah, I'll just conclude here. Which should be taken with a lot of caution, and we should not be hurrying through because there are a lot of fallacies which have been highlighted, and we should be looking forward to 4 more important trials which should give us the way forward as to why and how it has been a problem and how we can make it better. But till then, we have to wait because these are the ongoing trials which will still give us more information rather than rushing to a conclusion that the temperature target control should not be done. But I think these trials about the duration, about the use in in-house hospital arrest, I think these will give a lot of information. Till then, we should not come to a hasty conclusion that we should not be using targeted temperature control. So the key message is that you need to appreciate, to advocate. The evidence currently doesn't look too very bright despite having the new guidelines in place, and we cannot change rules without adequate evidence. I think that's what is all about evidence-based medicine. So do remember, disproving targeted temperature management still requires evidence, and it is still being advocated. Only the values have changed, and TTM continues to be an important modality. So my second advice to you is, please do not pay attention to whatever my counterpart says. I will speak in not anything any different than what I've spoken, the TTM2 and the TTM trial. Enjoy the AC here in this hall, which has a targeted temperature management control, and it's lovely post-lunch. Go to sleep as long as my colleague speaks. But always remember that disproving targeted temperature management still requires a lot of evidence and is still being advocated. The values have changed, and TTM continues to be an important modality. Thank you so much.
Thank you, Dr. Asif. Some strong arguments there. Has he managed to resynapse some of our neurons, or we are still with the same stance as before? To argue against the motion, now we have Dr. Subbareddy, who is the Medical Director of Apollo Health City, Hyderabad. Over to you, Dr. Subbareddy.
Good afternoon. Thank you, chairpersons. So already my friend took 1 minute extra to convince you people, and he completed the debate, I think. He spoke for and against TTM. I think he completed the debate, but I would like to again talk against targeted temperature control management. So hypothermia tried in many situations for the neuroprotection, not only for post-cardiac arrest, traumatic brain injury, spinal cord injury, refractory status epilepticus. And in this level of pyramid, level of evidence pyramid, whatever evidence you take, and then all the evidence comes against hypothermia in all the scenarios, not only in the post-cardiac arrest scenario. And then again, my friend told a lot of theory about hypothermia and potential benefits for therapeutic hypothermia. And all this is theory. And in real life, this is not working. If it is working, all these benefits are working, then definitely all of us would have used hypothermia. All our ICUs have ultrasound missions, but all our ICUs, we don't have surface cooling or temperature blankets with temperature feedback. So it is not possible to give high quality targeted temperature management. So it is not required. No need to invest on this because there is no evidence. all these are benefits in the theory. And my friend is talking about Harker trial and Bernard trial, which came in 2002, exactly 22 years back. And then do you want to take the evidence which we got it 22 years back? And these two trials were the basis for the initial recommendations. But if you see the limitations, the narrow inclusion criteria, very small sample size, and the attending physician not blinded, and then there is a selection bias, and no protocols for neuroprognostication during that time post cardiac arrest. So then 2013 we got TTM1 trial, that is temperatures maintaining between 33 and 36, and if you see there is no difference in neurological recovery or survival between 33 degrees centigrade and 36 degrees centigrade, and then the therapeutic hypothermia word has gone, and then now the new word came, that is targeted temperature control, and then there is no survival benefit. And in post-cardiac arrest scenario, there is no difference between 33 degrees and 36 degrees. And this is a robust trial when compared to Harker and Bernard trial. More number of patients involved, and then they have taken patients both from Australian continent and European continent, and then they included many ICUs in this trial, and then this is a more robust trial. And again, my friend conveniently taken some trials which are favorable for targeted temperature control, management, that is Hyperion trial. And there are a lot of flaws in the Hyperion trial, and in the normothermic group, it is not normothermia. In this group, many patients were having temperatures 38 degrees and some patients more than 38 degrees centigrade. Fever was not controlled in the other than TTM group. And there is a low fragility index, and a lot of people were withdrawn from the study in the Hyperion trial. And in the control group, they maintained temperature only for 48 hours, and the other group, they maintained this temperature management for 56 to 64 hours. So there are a lot of flaws in this Hyperion trial, and so we can't depend on this. So people argue saying that hypothermia is at least not harmful, so go for hypothermia or targeted temperature management. But how long we have to go for TTM? Is it 24 hours or is it 48 hours? But in this trial, they found negative effects of hypothermia. If you prolong more than 24 hours, the ICU infections were increasing, and then cardiac arrhythmias were increasing, and the ICU length of stay was increasing when they gave TTM for 48 hours than 24 hours. So clearly hypothermia is harmful, and it is not, people thought it is not harmful, so you can try, but in this trial they found it is harmful. And again, even for 24 hours TTM management, there are a lot of limitations in this trial, so it is not a very good trial. And then we got TTM2 trial, so that is like maintaining normothermia in these patients, and then there is no difference in survival, there is no difference in the neurological recovery. They have taken cerebral performance scale, and then there is no change in both the groups, normothermia group and then the TTM group. So if you see the story of TTM, so it is constantly changing. Initially, they said it is therapeutic hypothermia, and somewhere in 2010-13, they said it is not hypothermia, therapeutic hypothermia, it is high quality targeted temperature management, and now they say even that word also has gone, and even that word is also replaced, so there is no targeted temperature management. The terminology is changing, and then again, if you see the LCOR recommendations, they have changed the terminology, and then they suggested there is LCOR recommendation suggests actively preventing fever by targeting temperature of 37.5 degrees or less for patients who remain comatose after return of spontaneous circulation from the cardiac arrest. So the term also is changed. It is not targeted temperature control management, it is fever control now. Again, if you look at the European Resuscitation Council recommendations, so the monitoring core temperature is important. Remember monitoring core temperature. You have to monitor either bladder temperature or esophageal temperature, not the axillary temperature. Preventing fever, if it is more than 37.7 degrees centigrade, preventing is important. and and preventing fever for at least 72 hours. They have given clear-cut duration also, and exposing antipyretic drugs and cooling devices. There is insufficient evidence against for 32 to 36 degrees, and there is no role for using pre-hospital cooling with cold IV fluids. So if you look at the European Resuscitation Council recommendations from 2005, it is gradually the temperature target is increasing. Initially it is 32 to 34 degrees centigrade, then it is changed to 32 to 36 degrees centigrade. Now the LCAR 2021 recommendation clearly says you have to prevent fever, you have to maintain 37.7 degrees centigrade. There is no role for targeted temperature management. You have to control fever, for 72 hours, and then you will get benefit in the survival and the neurological recovery. And if you see the negative effects of hypothermia, if you see the adverse effects of hypothermia, and you take any side effect, it is there with hypothermia: renal dysfunction, liver dysfunction, electrolyte disturbances like hypokalemia, hypomagnesemia, hypophosphatemia, hyperglycemia, increase in infections, elevated amylase, elevated liver enzymes, and then cardiac arrhythmias like bradycardia, and then the biggest problem is shivering, and we don't have shivering protocols, proper shivering protocols in our ICU. What to do when the patient is shivering? Again, there is a lot of temperature variability that increases the mortality. So it is really hard to think about of any other medical intervention with such infinite range of consequences. I don't think any intervention will have so many side effects other than hypothermia. So my takeaways, don't look at the theoretical advantage, but if you look at the side effects, there is longer ICU stay, there is delayed awakening and ventilator associated infections, there is increase in VAP, and there is increase in arrhythmias, and then there is electrolyte imbalances, coagulopathy, and lot of negative effects of hypothermia. So there is no role for hypothermia. So every enzyme in our body has been evolutionarily designed to function at our normal body temperatures. Therefore, hypothermia will affect every chemical pathway. So there is no tissue, nor cells, nor extracellular space which will escape being altered somehow by hypothermia. So hypothermia is a blunt tool. So don't go for hypothermia. No role for hypothermia in the post-cardiac arrest. And I don't think if we decrease temperatures in this room, even if you have good lunch, you cannot take rest here, we go out. So there is no role for hypothermia. Thank you.
Thank you, sir. So there won't be rebuttal. So looking at the evidence, hopefully we have understood that there is no role for targeted temperature management and role for hypothermia. And definitely we should avoid fever. So moving ahead, last talk is on leadership in ICU, nurturing the key qualities. So it is important talk as even though you have subject knowledge, as a soft skill and leadership qualities if you don't have, it is difficult to lead your team and guide your team. So none other than I would like to call Dr. Narendra Rungta sir, Chairman and Managing Trustee. He is a past president of ISCCM, founder, president, Association of Critical Care Societies. He is a chief editor. He has written 5 books on critical care medicines. He has chaired 4 guideline committees of ISCCM. Over to you, sir. Thank you.
Good afternoon, chairpersons. Thank you very much. Bengaluru, ISCCM and JIX for inviting me. Probably selected me for very few of very poor quality gray hair on my scalp to deliver a lecture on this topic. Thank you very much also for picking me up from tomorrow's program and plugging me in today's program into brain. I'll try to awake you all from sedation, hypothermia, intracranial hypotension, a good dose of steroids and anti-immune drugs that you have undergone during last 1 hour. Talking about leadership and leadership in ICU, they do not have a lot of literature We do not hear a lot of talks and lectures on these topics in conferences. So mostly, broadly, I will try to share my own experience of last 35 years that I have experienced. Let me go through some incidences that we encounter in ICU and ICU-related environment. At 2 p.m., ICU chief looks at a case transferred by oncosurgeon into ICU with shock after esophagectomy. He has a close look at the X-ray chest post-intubation, discusses with teams and gives usual instructions, completes the round and invites the team for a cup of tea. Every sentence, every word that I have tried to put carries a lot of meaning. Takes the X-ray with him, goes back and discusses the case with the oncosurgeon. The oncosurgeon comes for early round and discusses the case with relatives and tells them that he will open the dressing under GA to make sure that there is no oozing leading to shock. He opens the case in OT, obviously takes out the foreign body, which was a gauze. The patient recovers, sent back. Nothing happens, no ruckus, no discussions in ICU, thanks to the wisdom of ICU chief. Another incident, inspection, protection, discipline and dignity. The ICU assistant consultant comes for sudden night round, as many of times we do. Smells of alcohol from the resident on duty, talks to someone on phone, obviously the chief of ICU. He takes the resident to the duty room for a cup of tea, convinces the resident to go home on account of not feeling well and does the night duty himself. Next day, things are as usual. The resident concerned learns a used lesson. Somehow or the other, is not exposed, he is not punished publicly, he is not reprimanded amongst colleagues. Taking on admin if need be, CFO of a corporate hospital would call young consultants and discuss about their role in the promotion of financial health of Department of Critical Care Medicine. ICU boss was bearing with it for some time, ultimately took an initiative, organized a meeting with his team to discuss the performance, including financial performance of the team. The CFO and admin executive were also invited. The boss was very firm and made it clear that he alone is accountable and answerable to any issue about performance of any type by the ICU team. The whole team was relaxed. Take charge of the situation. A sudden death in ICU, relatives creating a ruckus, making the whole ICU team to hostess. The ICU boss arrives to take charge of the situation and takes all the blame on himself, taking the worsening situation by horn and takes the situation to an acceptable logical end, protects the whole ICU team. There is an intra-departmental RAR means quarrel, fight, or, it was a term used by late Prime Minister Vajpayee, RAR nahi thanunga. Commotion in ICU following sexist remarks on a nurse by a young incumbent ICU resident. The ICU boss diffuses the crisis by reprimanding the resident and mentioned that nurses are the real owners of the ICU. They are indispensable and most respected members. And it brought the situation under control. There may be many more numerous incidences, occasions when the ICU boss has to play a role of leadership, act to resolve hot exchanges within the doctor's team, differences with the visiting multidisciplinary team, facilities in the ICU, around the ICU, equipment and equipment's health in the ICU, promotion of ICU team, and medical legal issues at all times, various times. The ICU leader, ICU boss cannot escape. If he wishes to be a leader, he wishes to continue as the real boss, own the responsibility, he cannot escape with mentioning there is nothing I can do. He makes me so mad and I must not intervene. He must lead by example. Leading looks at our other alternatives. He mentions controls feelings of his team and his own self, and he uses the term rather than I must do something different, then he says relatively I would prefer to do instead of what is happening around. Now I go to leadership. What is leadership? I have learned in my life, leadership is a character, imbibed, triggered and fueled by one's appetite to do different, which is better from what everyone else does. It's a drive to perform, excel and transform. It is applicable to an ICU leader as well, as much as to anybody else or any group as well. Leadership is different from being head, director or chairman or a CEO. It seldom comes by teaching or training. There are no classroom to teach you leadership. There are no, madrasas or temples or areas where you can go and learn teaching leadership programs. It comes through tenets of understanding, the wisdom of life, wisdom of acting in distress, wisdom of performing in challenging times. A bit inborn, driven by a desire to serve and not govern, feeling of entitlement is contrast to leadership values development. Inspiration of leadership comes from your own heroes, which you think that they are your lifetime heroes. Mine are Mahatma Gandhi, Sardar Vallabhbhai Patel, Sam Manekshaw, Ratan Tata, and my own parents. Sacrifice, courage, bravery, charity, and parenting. They have been the values that I observed in almost all of them. So if you follow them, if you are inspired from them, you tend to develop all those qualities, imbibe all those qualities within yourself and act on them. Tenets of leadership include guidance, providing solutions, targeting the goal, be motivated, motivate others, communicate clearly, and don't hide from communication, plan things meticulously, have a vision, and give direction. Follow a direction and give it to others, your team members. A leader dares to embark on an untreated path. He doesn't follow what has been being followed conventionally. He finds his own goals, own targets, and treads a new path altogether, which is motivating for others. And most of the time, true leaders are successful. A leader strives to excel in each and every act that he tries to perform successfully. 7 key steps to become an exceptional leader, which applies to an ICU leader also, are confidence, passion to profession, mastery plus passion, communication, additional responsibility taking, transferring of the legacy, and enrich your own inner self. Let me just, confidence, you must look confidence whether it is a situation of success or distress or failure. You must take everything with confidence. There should be no evidence of distress or depression on your face or in your eyes or the way you talk or present yourself. Sometimes when everyone is waiting for someone else to take the first step, the leader takes the first step, initiated himself, rather than waiting for others. An ICU leader truly has to be extremely knowledgeable. When it comes to discussing any topic, subject, or a patient, if he looks at others for information, for knowledge, then he cannot be a true leader. So he must be extremely knowledgeable, should be full of skills, hard work, working on deficiencies in development of skill. He must work on and acquire good skills. Skill plus knowledge is ultimately what we do in ICU. If you are a good combo of skill and knowledge, excellent clinical outcome is almost guaranteed. Outcome doesn't mean always patient going home. Outcome means what you have thought at the time of diagnosis, initiating the management strategies, you know what is going to come up. Achieving that. Evidence-based, adopt best practices. We practice evidence-based medicine. Not only talk about it, actually transfer it into practice and adopt the best practices that are existing as on date. Best leaders adopt best practices. Best practices ensure better outcomes. Ladies and gentlemen, learn and update. Go to journal houses. Acquire some password to good libraries. Visit centers of excellence. Attend international meetings, national meetings of good strength, which gives you good knowledge, good skill, good power. I'll take another. So, integrity, judgment, competence, vision, persistence, and humility are important ingredients of a true leader. All leaders usually follow their own passion. They don't depend on others. They don't mimic others. They have their own passion. They may be good teammates. They may be good sportsmen. They may be good speakers. They may be good authors. They follow that. They communicate very, very well, clearly, which has a meaning which can be derived by the youngest of the team members. Leadership is about taking responsibility and not making excuses. Don't make any excuse. If you make excuse, you cannot be a leader. Strive hard to contribute whenever, wherever. Money is not everything in life and career. Therefore, don't sacrifice your values. Don't sacrifice the respect for money. Pass away the legacy. This is a rare tenet that we do not see in many of us. So passing the legacy, passing the baton to the next generation is very, very important, and that this passing of legacy should be complete, should be total, and there should be no interest left whatsoever in your mind and heart about what you have developed during your tenure. Team building is very essential. It works. A leader knows interdependence is of higher value than independence. If you want to walk alone, ekla chalo re doesn't work most of the time. Ek akela hi chala tha, log aate gaye, milte gaye, karwa banta gaya. So you have to provide them value, you have to provide them respect, guidance. It is very important. You cannot become a true leader unless you enrich yourself with ideas, values, motivation, literature, and your inheritance. So a little bit of yoga, sleep early to success, rise early, beat the alarm. Early to bed, early to rise makes a man perfect and wise. That is a good formula. Don't allow stress within yourself. Don't allow stress in your colleagues. If you detect one, manage it very fast, immediately, without letting it go beyond control. Shun bribery. I want to call upon my younger colleagues. Bribery, gifts in any form from your younger teammates tames your conviction. Just 30 seconds. Firm in challenging times, it leaves permanent crack in building of your leadership qualities. To remain in good steam, you should be a good listener. It provides free information. Handful of it fosters empathy and trust, minimizes misconceptions, and help you in resolution of problem. Leader has something extra, extra sense, extra hour of work, extra performance, extra patience, extra sincerity, extra drive, and extra caring. That is very important. You have to possess. Mahatma Gandhi said, a sign of good leader is not how many followers you have, but a true leader is one who thinks how many leaders you have created or produced. So therefore, ladies and gentlemen, I call upon my younger colleagues to arise, awake, stop not till the goal is reached. Swami Vivekananda said long back, my last slide, it will give you good reason to be proud of yourself and be proud of your teammates in critical care medicine, in your ICU, in your country and outside your country. Thank you very much.
Thank you so much, sir, for guiding us through this important virtue about leadership in ICU, which is very essential. Since we don't have a question answer session, we declare the session as closed. Thank you.